It's now time to look at critical factors for successful function of the lymphatic system. Hydration is one, so we're going to look at that first. Adequate deep sleep is another. So is diaphragm function, visceral movement, and fluid flow movement through the lymphatic system, and of course, musculoskeletal movement. So let's look at hydration. So if I'm going to say to you that there's a minimum amount of hydration that a patient should have to sustain their lymphatic and visceral system, I've got to give you some numbers, right? So we can look at it from how many kilocalories a basal metabolic rate of an individual might have. We're not likely to know that with our patients. We probably can find out their body weight. So that can either be in pounds or kilograms. And we can use the Exos system of 0.5 to 1 ounce per pound of body weight. Convert that to milliliters per kilogram. We get a number of between 33 and 66 mils per kilo body weight. Precision Nutrition, they quote 30 to 40 mils per kilogram of body weight. Of course, people that are more active will need higher milliliters per kilogram. People that are less active, not going to need as much. So we do have an example on that bottom rung there that's just based on a 49-year-old man, 190 centimeters and 100 kilograms with a basal metabolic rate of 2,000 kilocalories per day. There's an estimate of 1.5 to 2.2 liters per day. The Exos and Precision Nutrition guidelines based on kilograms would say that that's got to be more likely of 3.3 to 6.6 liters per day, depending on weather, temperature, and activity, or Precision Nutrition's 3 to 4 liters per day. That would be adequate nutrition, or hydration rather, for an individual whose lymphatic system and visceral system needs to be minimally or even optimally hydrated. And the reason that we need that is because a large percentage of the fluid sits within the interstitial fluid, okay? So it's going to sit inside the cells or outside the cells, and when it sits outside the cells, it's either in the blood system, 25% of it's in the blood, or the lymph, or the veins, and 75% is in the interstitial fluid between vessels and between tissues. And so the behavior of that interstitial fluid can give us information about the function of the body. So what happens when there's inadequate hydration? Well, that's a really good question. Let's have a look at it. Symptoms of misbehavior of the lymphatic and visceral symptoms, they appear when there's inadequate hydration. Well, if I'm going to say that, I've got to tell you what the symptoms are, because we're going to do a subjective history. We need to know if our individuals have symptoms that might be related to lymphatic or visceral dysfunction. Here they are. There are several. We've got foggy brain, that's one option. You've got memory and concentration difficulties. You can have mood disturbances or irritability. People can be more sensitive to stimuli that they wouldn't necessarily consider themselves to be sensitive to. That's the mood disturbance or irritability. You can have reflux or indigestion. You can have a loose bowel or constipation as well as bloating. And the last one's interesting, neuroinflammation. Well, that suggests that the nervous system can become hypersensitive due to the presence of an inflammatory process that's going on. These are misbehaviors of the lymphatic and visceral system symptoms. The neuroinflammation that I described as a symptom of lymphatic and visceral dysfunction, it shows up as pain or increased sensitivity to movement, strain and stretch. Well, that shows up in clinic as a mobility dysfunction, an MD, or a stability and motor control dysfunction, an SMCD. That's where the central nervous system's not being able to control available movement. It's got to do with pain or sensitivity to strain, and then you get different coordination of muscles to control movement. You may have altered breathing due to stress related to that pain or sensitivity. Then you can have wincing or grimacing or guarding, or in fact a person may withdraw from passive handling because of that sensitivity. We need to look at the second critical factor for success of the lymphatic system. That's called adequate deep sleep. Now, adequate deep sleep is approximately 7 hours for an adult between the ages of 18 and 60. And approximately 25% of that should be deep sleep, which means in the vicinity of 1.5 to 2 hours. So people go through two types of sleep in each cycle. They have rapid eye movement or REM sleep, and they have non-rapid eye movement or non-REM sleep. So there's one cycle of REM and there's 3 of non-REM in each cycle of sleep. So what happens is the non-REM is divided into 3 stages: light, deep, and then deepest or deeper sleep. And then a person will cycle through these stages 4 or 5 times every night, and the order is N1, N2, N3, or the non-REM stages, and then finally with REM sleep as well. So what happens is each cycle will last between 90 to 100 minutes, and the first REM stage or dreaming stage is quite short, but as sleep progresses it will get longer compared with non-REM. So in this table we can see that non-REM 3 constitutes 25% of the total volume of sleep, which is in the vicinity of 105 minutes in total, shared between all the cycles. And this particular cycle, it's where the body repairs and regrows tissue, it builds bone and muscle, strengthens the immune system, and it's also related to where neurotoxic waste is drained from the glymphatic system. So this circles us back to the brain. If you're trying to clear neurotoxic waste and you don't get enough sleep, then it doesn't clear adequately and you end up with a range of symptoms such as neuroinflammation or reflux, bloating, loose bowel, constipation, memory and concentration difficulties, mood disturbances, irritability. And foggy brain, of course, is the other one. So we need to look at some of the factors that can limit deep sleep, because as a clinician who works in the field of physical therapies, we should be understanding some of these things because they can contribute to a person having clinical signs of movement dysfunction or pain. What can limit deep sleep? Well, I'm glad you asked. Elevated body temperature is one, because the liver tends to have a peak metabolism between 1 and 3 a.m. So anything that leads the liver to increase its metabolism can elevate the body temperature and bring someone out of a deep sleep. Of course, if the room's too hot, that's another one. Menopause, that can also raise the body temperature. Too many clothes, that can raise the body temperature. Too much alcohol and sugar, they can cause the liver to go into an increased metabolic state, elevating body temperature, reducing the deep sleep. A virus, that can bring the temperature up as well. So let's look at some of those things. Alcohol, sugars, a lot of water before bed. Why is that the case? Because you've got to process it and it's going to go through the liver. If you have a late meal, same circumstance, increased metabolism overnight. And of course, fever and an elevated heart rate and body temperature associated with having a cold, which may not necessarily be feverish by the true definition. Of course, if you have interruptions to sleep by children or partner or pets, that can also limit deep sleep. So we look at all these different things. We've got pets and partners and fever and late meals and alcohol, a lot of water before bed, being unwell, and of course, sugary, delicious dessert foods. Now, we can track this as a clinician, and so can our clients. We use a sleep app. My Apple Watch is the preferred choice, and there's an app called Auto Sleep. It's in the vicinity of 8 or 9 Australian dollars. It tracks my Apple Watch, which I charge before I go to bed, and it tells me how much deep sleep I'm getting and how much total sleep. In this particular example, 17% of my cycle was deep sleep, which is beneath the 25%. But there are other circumstances that will see it rise and fall, and let's have a look at some of those. Here's an example of getting 35% of deep sleep, which is 2 hours and 51 out of a total of 8 hours and 5 minutes. In this example, 27% deep sleep, which is 2 hours 32 out of a total of 9 hours 26 minutes sleeping. In this next example, we've got 9 hours and 1 minute of sleeping, but we've got only 45 minutes of deep sleep, which accounts to 8%. We've got an elevated heart rate, and what we can see there is waking up just around the 3 o'clock mark. And now, at that particular date, I was suffering from a virus. So here's another example of how it affects deep sleep. So what happens if you've got inadequate deep sleep? Well, you get inadequate clearance of neurotoxic waste overnight. And then you get symptoms of misbehavior of the lymphatic and visceral systems. The lymphatic clearance is reduced by as much as 90% in the awake state. What that means is if you're not in non-REM 3, then your neurotoxic waste clearance is reduced. And if you don't get enough non-REM 3, you're going to wake up with neurotoxic waste not being cleared adequately, and there's all the symptoms that we talked about. So a major function of sleep appears to be that the lymphatic system is turned on and that the brain is clearing itself of neurotoxic waste products that are produced during the wakefulness hours. Now, the brain lymphatics and glymphatics is also relying on adequate hydration, as we mentioned earlier, and it's also very much related to diaphragmatic function. So the diaphragm is a huge pump, and so it's going to push a lot of fluid around. So we see that if you can consider that as that fluid and pressure changes, what could be the effect on lymphatic and blood flow between the abdominal cavity and the thorax or the mediastinum, and what could be the effect of those pressure changes related to the diaphragm on the parietal and visceral recesses? Well, we can see in this particular image that there's a lot of blue arrows that indicate the flow of serous fluid flow. You don't have to remember all of those. The point of it is that there could be fluid flowing in all different directions when the diaphragm is functioning and when there's enough hydration and when there is congestion changes or releases of congestion in the abdominal cavity. From the dorsal aspect of the body, we can see that the lymphatic flow between the dorsal skin and then where it's going to flow to in the lymph nodes, well, that could also be influenced by pressure changes within the abdominal cavity and in the mediastinum and the thorax as leveraged by movement of the diaphragm. So the connective tissues in the torso, the upper limb and the lower limb, they can be impacted by diaphragmatic movement. It's not just an opinion. There's research on this, and we've got some great schematic flowcharts that look at the effect of the diaphragm on fluid flow and all of the other biomechanical and biochemical changes that we see. This schematic by Leon Chateau tells us that we should consider the effect of dysfunctional breathing on lymphatic and blood flow between the abdominal cavity, mediastinum, serous fluid flow in the parietal and visceral recesses, and areas of connective tissue in the torso, upper and lower limbs. Take a little bit of time to look at that circled section. Upper body tension. This is commonly occurring when you have dysfunctional breathing, and it's related to anxiety, the body being in a fight or flight response. That's called sympathetic behavior. I bring that up because in the clinic, if you can create a soothing environment where a person can switch towards a parasympathetic state, you may see a change in upper body tension. Not only that, but you'll see an increased change to the vagal nerve outflow, which then causes a change to the esophagus function, stomach function, small intestine, large intestine function. If you can create a state in the clinic where parasympathetic nervous system activity is improved, you're going to see a change in fluid flow. And when you see that change in fluid flow, you can detect a change in local biomechanical evaluation findings, movement findings, and pain. In this slide, we see upper body tension is highly related to dysfunctional breathing. Maybe it's related to the pressure changes. Let's look at some of the other effects. We see the aching shoulders and head and neck pain. Well, what if it's possible that the skin, the connective tissue, the interstitial fluid around the head and face and neck, what if that's congested with lymphatic fluid? What if it's congested with neurotoxic waste? Is it possible that that could cause an ache? Of course it is. We can also see that muscles may function poorly. That's related to low calcium. Well, maybe it's also related to a low exchange of solutes, metabolites like calcium and its derivatives through the different channels and the interstitial fluid. Now, what's the effect of dysfunctional breathing on pain? Well, again, we see these nociceptors become more sensitive, and that increases the pain perception. So that's that neuroinflammation occurs with dysfunctional breathing, inadequate sleep, decreased hydration. And last but not least of importance, dysfunctional breathing can lead to chronic pain as well. So let's move on now and look at some of the other research that verifies this beautiful schematic. So there's a screening protocol that identifies dysfunctional breathing, and some of the conclusions from that is that normal breathing, which is considered to be diaphragmatic breathing, includes the synchronistic behavior of the upper rib cage, lower rib cage, and the abdomen, and it requires proper use of the diaphragm. So dysfunctional breathing, where that synchronous behavior doesn't exist, has been linked to a number of common chronic health conditions such as low back pain, neck pain, anxiety, and depression. And it's been reported that approximately 50% of individuals with low back pain and 83% of individuals with anxiety will demonstrate some form of dysfunctional breathing. We can also see some research that says that patients with low back pain that's chronic, they appear to have an abnormal position and a steeper slope of the diaphragm, which might contribute to the cause of the disorder of chronic low back pain. We won't dive too deep into that just yet, but later we're going to come back and see how the position, the slope, the behavior of that diaphragm, how it might be part of the reason individuals got low back pain. Let's move on. In this particular paper by Michelle Smith and her colleagues, we see that middle and older women have got an increased chance of getting back pain if they have dysfunctional breathing compared to those without breathing problems. So in a case series of 29 patients with neck or back pain who had stopped getting better with manual therapy and exercise, they've all been identified as having end tidal carbon dioxide low ratings. So when breathing retraining was conducted, that improved them as well as their pain and their function. And so again, we see that link between breathing and musculoskeletal disorders. If we have a look at other critical factors for successful function of lymphatic systems, visceral movement is one. And that brings us to the slide that we saw earlier about the symptoms of dysfunctional lymphatic system and visceral symptoms. In the slide, we're going to highlight now that bloating, loose bowel, constipation, and reflux as symptoms of misbehavior of the lymphatic and visceral systems. So again, what's critical to the lymphatic and visceral systems is that the viscera actually can move. And so if we consider the effect of inadequate visceral movement on lymph flow, blood flow, serous flow in that abdominal cavity. And you consider that in this particular picture where there is a hook that's grabbed hold of a bunch of the abdominal cavity organs and it's pulled it away, we can see lymph tissue behind. We can see the diaphragm at the top with its crura. We can see the psoas and we can see the L3 transverse process. So wouldn't it be possible that if fluid flow or lymphatic flow or tissue pressure in any organ, if it's misbehaving behind the parietal peritoneum or that abdominal cavity, could it tug on that L3? In clinic, I see this happen all the time. And when the fluid flow changes, as per a tell, if you go back and reevaluate L3, or in fact L4 and L5 and L2 and L1, it's very commonly seen that you see a change in behavior of that vertebral body. Consider also the effect on the diaphragm, the crust there that's shown there, or which is a singular for crura. It's an attachment on the spine, diaphragm function, fluid flow function. Is it possible that lymphatic flow, fluid flow, tissue tension in that abdominal cavity could also, through its attachment at the diaphragm and the spine, change behavior of the spine and anything that the diaphragm is involved with? I think that's possible because I see this happen all the time. What might it look like clinically? Well, breathing dysfunction, spine mobility dysfunction, motor control dysfunction, and any regionally interdependent part of the body that depends on diaphragm function and spine function to be working well. Second to last of the 6 critical factors is we see flow through the lymphatic system as being critical. Let's look at what that flow should look like. From the anterior aspect, we see the lymphatic actually follows the lines of those superficial veins. The umbilicus is a point of reference. Below it, lymph in the anterior abdominal torso area is going to flow downwards to the inguinal area and the hips, and then it'll go deep inside the abdominal cavity. Above the umbilicus, it's going to travel to the axilla, and some of them are going to go to the sternal lymph nodes as well. So consider that if you have inadequate flow of lymph on any tissue of any system, it can be related to congestion, dehydration, reduced mobility, reduced deep sleep, dysfunctional breathing, that you may see symptoms in the tissue on the front. And that may show up as a symptom that a person's come to see you about. From the back, let's have a look at that. We see that the dorsal tissues are going to drain to the axilla if it's above the umbilicus. It's going to drain to the inguinal and groin regions and then deep into the abdomen if it's below the umbilicus. And the back of the leg and the calf is going to drain around to the front. But if it's deep, it's going to get into the popliteal fossa. So that brings us to the final critical factor, which is musculoskeletal movement. Now, if we have a close-up look at the skin, we can see that there's a subcutaneous tissue known as superficial fascia. And then we've got deep fascia and skeletal muscle. In the face, there is no deep fascia, which is why there's a lot of loose movement of skin over the face. But for the rest of the body, we've got those superficial and deep fascial layers that overlie skeletal movement. And it's in that subcutaneous tissue where much of the lymph vessels exist with blood flow as well. So that consider the effect of skeletal movement on the flow of lymph in any tissue of any system. Consider the effect also of skeletal movement on regional interdependence up and down the kinetic chains and through the fascial system that binds all systems. So if you're thinking, well, that sounds familiar, it's got to do with acupuncture meridians. Now, I'm not jumping across any cultural systems here. There is research that says that acupuncture meridians are part of the human extracellular matrix and that fascia was an important part of the anatomic substrate of acupuncture meridians, which says if we go back to the previous slide, skeletal movement is going to influence lymphatic flow in the skin, and that lymphatic flow is heavily connected to all the organs and all the blood vessels in all the tissues of the body. And that subcutaneous tissue, which has superficial fascia in it, actually contains the anatomical substrate of the acupuncture meridians. And it's the acupuncture concepts which describes how we are connected in all parts of the body to the health of our movement and our tissue and our organs. So we're starting to see a picture come together now that musculoskeletal movement matters in its health of the viscera and the fluid flow and vice versa. So we see that when you do a reinforcing treatment might be a lifestyle change or a nutritional supplement or some sleep advice or some exercise, that it can help maintain the movement that you've achieved by doing manual therapy, which we call a reset. And if you're doing exercise, which is one of those reinforcing treatments, then if you're doing it along the lines of fascia, then it's reasonable that you are holding yourself accountable to sustain the improvements in movement dysfunction and fluid flow dysfunction. So let's look at that connection between the fascia, the substrates of acupuncture meridians, and how that can relate to what we're trying to do down the track, which is exercise and also manual therapy. So we see that the superficial front line on the left looks eerily similar to the stomach meridian, and that's because there are fascial connections that have been proven to be found as an anatomic substrate for acupuncture meridians. On the right-hand side, we see the lateral line and gallbladder meridian. So I see these and I think, well, I know an exercise that can reinforce movement along the fascial lines of the lateral line. Oh, isn't it interesting that we might also see a fluid flow at the same time as we do that movement, and it might be related to the organs of the abdominal cavity. Here we see the spiral line from the front and the back and how closely it relates to the stomach and bladder meridians. Again, fascial lines, lymphatic systems, organs, they're all related, and it gives us some input as to how we might do manual therapy to either musculoskeletal system or the lymphatic and visceral systems, influencing each other. Here we've got the arm lines of superficial and deep and how they relate to some acupuncture meridians known as the triple energizer meridian and the small intestine. And now we see the superficial back line and how it looks similar to the bladder meridian. And now we've got the superficial front arm line and the pericardium meridian, and that's going to show up in one of the fascial techniques that we do for thorax fluid flow in the live class. The deep front arm line and the lung meridian, again, it shows up in one of the practical techniques that we do for manual therapy. Looking at our deep front line and the liver meridian, it's no surprise to know that when you influence the prevertebral fascia of the spine, it's got connections to the parietal peritoneum. These are anatomically known, and therefore it shouldn't be much of a surprise to see that they are linked. Now let's have a look at a little bit of science that relates to the effect of clinical therapeutic strategies. That's what we do as physical therapists and other clinicians. And its effect on the vagus nerve and its effect on the fluid exchange between the tissues of the body and the brain. It has been shown that vagus nerve stimulation, which is a very specific therapy, it's not just the same as a hands-on massage or a joint mobilization or acupuncture or cupping or gua sha or any other phrase that you might use. Vagus nerve stimulation is a specific, perhaps a clinical neurophysiological technique. However, the principles apply here. Let's keep reading. Vagus nerve stimulation, therapeutic strategies which are already being applied in clinical settings, they may induce an intended effect and possibly unwanted side effects by altering fluid exchange between the brain and the tissues. And this can have a broad ranging implications in the treatment of various pathologies of the central nervous system. Now, does that sound familiar? We've got a central nervous system with all of our clients. We've got pathologies that relate to pain and motor control and altered sensitivity to movement, which shows up as mobility dysfunctions, and it appears that if you stimulate the vagus nerve, it causes fluid to change between the brain and the body tissues. I think we can get something going here in terms of practical. Not that I think, I know, but the science supports it. Now, one of the ways we do that's got to do with something called neurovascular coupling. Neurovascular coupling, or NVC, is the mechanism by which there's an increase in nerve activity, and that changes blood flow in the brain, and that causes enough blood to go to the different parts of the brain based on local cellular metabolism. So this is a mechanism that actually occurs. You need brain blood in this part of the brain, so then there's a change to the output between nerves and blood flow to make sure plenty of blood gets there. Plenty of science around this. However, it's activated in animals using mechanosensory stimulation. Well, that's a big word in capital letters there, but mechanosensory stimulation. Well, I'm pretty sure manual therapy neuromodulates those mechanosensory receptors. So what we do with our hand can change what happens to blood flow to different parts of the brain. You can also do electrical stimulation on nerves in the body and also in the brain, and that can change different blood flows in the brain. But it's that mechanosensory stimulation that says we can alter what happens in the central nervous system. Not much of a surprise to those of us who've studied a little bit of this brain and body interactions. Which brings me to my final slide for this particular part of the lymphatic and visceral manual therapy class. And that is that when you do manual therapy of the lymphatic system and the visceral system, it has an effect on musculoskeletal pain and movement dysfunction. And there's science behind it, there's art behind it, there's clinical theory behind it, there's oriental acupuncture meridian theory behind it that's been matched with scientific studies on its connection to the anatomical substrates of fascia and how they relate to the places where the lymph flows in the skin, in the abdominal cavity, in the superficial collection of lymph nodes in the face and the neck and the torso and the thorax and the skin and the groin and the hip and the back of the knee and all those areas. And so consider that when you do a reset technique, which is something where you change the behavior of the body, that's a reset, and then you add something to reinforce it or maintain it, and then you retrain the way the person uses their body with that newfound behavior change. Consider that those techniques, they can neuromodulate, which means it can change the nervous system. You can also change the blood flow system in the brain through neurovascular coupling. And it can influence tone in skeletal muscle related to congestion of fluid, fascial tension, and not just locally, but also distant from the region being treated. So we can detect this if we pay attention to a systematic musculoskeletal assessment, and within that treatment, signs of any change in behavior. See you at the class.